Hello, I'm Judy Kidger. I'm a senior lecturer at the University of Bristol, and I'm going to discuss the impact of a study that the School for Public Health Research funded during its first 5 years. Following evidence we'd gathered that staff mental health in schools was neglected, we formed a team across Bristol, Exeter and King's College London universities and received SPHR funding to develop and test out a mental health intervention and its evaluation in secondary schools. The intervention had two components: training staff in mental health first aid, who then set up a peer support service as a first port of call to support their colleagues, and training staff in supporting student mental health. Mental health first aid is evidence-based training developed in Australia that equips people to spot the signs of mental health difficulties in others and to have the confidence to proactively provide support. Our study had two phases. The first was a one-year feasibility study in 2 schools where we tried out the training and outcome measures and made changes where needed. The second phase was a pilot randomised controlled trial. We recruited 6 schools and randomly allocated them to receive the training and peer support service or to be a comparison with no input beyond usual practice. These were our research questions, which covered the feasibility of the intervention itself and the mechanisms by which it might work. We successfully carried out the study, and despite its small scale, it has led to some important impacts. Our findings fed into a new product developed by Mental Health First Aid England, specifically a one-day course that was more accessible for teachers and had more of a focus on practical help. We also raised the profile of teacher mental health. 2 papers that we produced from this study highlighted, number 1, that teachers do have poorer wellbeing and higher depressive symptoms than general populations, as shown in the graph. And secondly, that there's an association between poor teacher mental health and poor student mental health. And although these things sound intuitive, good evidence was lacking before our study. Our findings about the importance of teacher mental health were also included in a report by Public Health England. A key impact was that our evidence regarding the feasibility and acceptability of the intervention and its evaluation led us to a successful bid to the National Institute for Health Research's Public Health Research Programme to conduct a full cluster randomised controlled trial in 2015. This full study has now concluded with further impacts to report. Unfortunately, we did not find the intervention, when fully evaluated, led to improved mental health outcomes in staff or students at population level. However, we did find evidence in our process evaluation of increased knowledge and confidence among teachers in the intervention schools to support their own mental health, that of their colleagues, and that of their students. As study principal investigator, I was invited onto the expert reference group for a Department for Education rollout of the mental health first aid for schools and colleges, which involved 1 teacher per every secondary school receiving the training. And we further raised the profile of teacher mental health through papers and presentations to policymakers and school staff. And in particular, we used our process findings to highlight the need to address workplace causes of poor mental health and to create structural changes. These are the links to the 4 papers reporting outcomes from the main study. And I'm really happy to give the last word now to a teaching professional who was on our study team and who reflects here on why the study was valuable to those involved.
And I certainly noticed that my practice, my personal practice, was enhanced from my involvement in the scheme, and also my understanding of supporting others with their mental health, students and colleagues, and also advising my head and SLT on what was available, what we could possibly do to enhance our whole school provision around mental health. So certainly there was a profile raising consequence of having been involved in the study for me, for my school, and I know from colleagues in other schools that they felt, having been part of the pilot and also all part of the research project, that this was also true of their schools. So without question, a positive outcome. I also feel that where staff were involved in the project, internal school training, CPD, continuing professional development occurred, so that staff could tell other staff members about the training that they had received. Again, not just profile raising, but also enhancing practice across the board for a number of different staff from different parts of the school and different roles within school. So the benefit of the involvement in the scheme, and also in the nature of the provision that the WISE project implemented, whether you were part of the pilot or the research project, was really positive.
Thanks very much for listening.
In this research, we wanted to find out if we could work in partnership with industry to get fish and chip shops to offer small portion meals to all customers at all times. Public health teams have found it difficult to engage with takeaway owners, but we discovered that wholesale suppliers and fish and chip shops are trusted by owners and offer a way to influence portion size. We worked with Henry Colbeck, who are a major supplier to fish and chip shops in the north of England and throughout Scotland. Together, we developed a team spirit event to which a select number of fish and chip shop owners were invited. At this event, Henry Colbeck staff detailed to owners the financial benefits of offering small meals. Colbeck were able to offer a range of packaging for fish and chip shop portions, as well as promotional posters for owners to display in their shop to inform their customers. Working with 12 local participating businesses, we collected a range of data, including business setting, sales, and customer, owner, and supplier experience of the scheme. We found that owners and customers welcome the scheme, demonstrating that it is feasible to work collaboratively with industry in this sector to promote healthier takeaway food. However, there remain wide variation between individual fish and chip shops, and more work is needed to define the ideal size for healthier small portions.
The Foodscape project was a fantastic experience. It brought together many minds within the industry to talk about and discuss the real issue of portion control, to the point where it actually spurred Henry Colbeck on to think creatively about how to help combat this from a commercial point of view.
So when we first got involved in the Foodscape, what was interesting from our point of view at Longsands was we were looking at offering a smaller portion. So what we did, we introduced a smaller size box. The portion still looked a big size, but because it was in the correct size packaging, people were opening the box and actually seeing value for money. With introducing our packaging and then getting involved with Foodscape, the two tied in. And what helped me promote the smaller portion was the feedback that we got from the customers through Foodscape.
In 2014, the Lilac team was funded to undertake a study investigating the impact of reducing the cost of using local authority leisure facilities. The research was funded by the Phpes scheme and was led by Ben Barr and myself, Emma Halliday, at Liverpool and Lancaster universities. The context for the research is that there were continue to be inequalities in participation in physical activity in the region, and local authority professionals had approached us because they were interested in understanding whether their investment in free or concessionary leisure was having any impact on participation for local populations. The research treated the leisure pricing policies of these local authorities as natural policy experiments to evaluate the impact on health inequalities, and a total of 7 local authorities took part in the research. The methods include qualitative methods with members of the public and professionals, as well as quasi-experimental techniques involving the extraction and analysis of leisure systems data, as well as existing survey data. There was a strong focus on co-production and engagement in the research, and in particular, we'd really like to thank our local authority partners and also members of the public who were involved as advisors to the research, because their contribution was extremely important to the success of the research. Practically, there was involvement of local authority teams in the in helping us to navigate and interpret the leisure systems data which was available on participation in facilities across the region. We also set up a research advisory network to help with the transferability of the research out with the immediate region. So this involved, for example, representation from the Association for Public Service Excellence and Public Health England at the time. And there was a particular focus on public involvement of local residents who were living in the local authorities where the research was being carried out. So turning now to look at some of the key headline findings, certainly from the public interviews and focus groups we conducted, we found that affordability was a major factor affecting how people used or did not use leisure facilities. This particularly was a factor for people receiving welfare payments in low-wage households or also people who were retired. And it led people to navigate leisure facilities at different ways. For example, where free leisure was provided through free universal leisure schemes. This led people to only attend when charges were free, or in other cases to only attend when charges were provided at off-peak times or were offered in other concessionary ways. We also found that people talked about pay-as-you-go options being the most manageable way of using leisure facilities because it involved not having to commit, but of course it was the most expensive. And as this quote highlights, this individual talks about the cost of milk and bread, but also wanting to keep active and seeing the amenities in their local areas, but not being able to afford to go in. And then turning to look at the findings for health inequalities at the local population level, certainly we found through investigation of two schemes, a universal free offer in Blackburn with Darwin and free holiday swims for children in Blackpool, that there were significant impacts on participation, and particularly these were seen amongst more disadvantaged groups. And we also saw that beyond those schemes, that concessions for those aged 60 or older also had some impact on, at least temporarily, delaying the decline in participation. In terms of impacts, we've produced outputs and resources and contributed to NIHR resources such as a Moving Matters review. Ben's work on leisure systems data has helped to build capacity locally, and also the research has had a direct impact on local decision making for one local leisure scheme, and as well has contributed to making the case for further investment, which is actually now the focus of a further evaluation led by Ben. So to conclude, and this slide provides our contact details and also provides a link to a case study on the SPHL website where you can find all the outputs from the resource and links to further information. Thank you.
Hello, I'm Jenny Phpes, a member of the School of Public Health Research through the LILAC collaboration between Liverpool and Lancaster universities. And I'm going to be talking to you about the Public Health Practice Evaluation Scheme. The Phpes, as we affectionately refer to it, was established in 2012 when the school first started, and it aimed to contribute to the school's overall objective of producing high quality research evidence for public health practice that would improve health and reduce health inequalities. Phpes was innovative in that it sought to develop new, more inclusive, equitable research relationships between SPHR academics, the researchers, policymakers, and practitioners in local authorities and civil society organisations, and always included public partners. So the aim was to work in partnership with these colleagues to evaluate local initiatives that have potential to improve population health and reduce inequalities, that could be transferred to other areas if found to be effective, and that have not been robustly evaluated before. Since the scheme began in 2013, we've funded 26 local initiatives. In 2017-18, we conducted an internal evaluation of Phpes to find out what had worked well and how it could be improved. We spoke to SPHR researchers involved in Phpes projects and also to public health policymakers and practitioners in different sectors, who had been involved in Phpes evaluations or who had submitted applications that were not funded. The highlights, the main findings from the evaluation was that Phpes provides much needed resources for local evaluations of initiatives, that it produces evidence on what works, but also crucially on why things don't work, so that they can either be adapted, improved, or stopped. It strengthens relationship between practice and academia, but there can be tensions. For example, practitioners have more pressure to show that things work. Academics are under pressure to publish, but these pressures were always effectively negotiated within the Phpes projects. The types of improvements that were highlighted included the need for more support in the development of applications to the Phpes scheme. These applications come from practitioners, policymakers. More process evaluations into why things worked or didn't work alongside impact evaluations. More flexibility to respond to delays implementing interventions. So for example, delays in funding or staff being in post. Funding for the dissemination of findings to ensure that the initiatives can be taken up in other areas when they're found to be effective. And more feedback on why applications were not successful. There were also a concern to try and reduce geographical inequalities in opportunities to apply to Phpes. The unevenness of these opportunities is an inevitable consequence of the fact that the members of SPHR are not geographically spread across the whole of England. To give you some idea of that, here is a picture of the applications that were received and the projects that were funded in the 2019 call, the latest Phpes call. Please ignore the detail here, just look at the pattern. So overall, we had 91 expressions of interest to this call, 44 outline applications were submitted, and 10 local initiatives evaluations of local initiatives were funded. And as you can see, although the spread across the country has improved over time, it's still very much concentrated around SPHR members. You can see here Phpes in the northeast, Sheffield, we've got Cambridge, and of course there's a concentration in London with the London School of Hygiene and University College London, concentration around Bristol, and a concentration around Lilac in the northwest. In this quinquennium, we have 2 new members, Exeter down in the southwest, so that will increase opportunities here, and in the Midlands, a collaboration between Birmingham, Warwick, and Keele. So let me give you some examples of the type of projects the type of local initiatives that are funded, are evaluated through the Phpes scheme. The one with the red circle is the one that Emma Halliday told you about just a little earlier, with local authorities reducing the cost of leisure facilities. What was the impact of that on health and social inequalities? As you can see here, the Phpes projects that are evaluated are very diverse. So we've got focus on oral health intervention, interventions preventing domestic abuse, interventions to promote smoke-free homes, an intervention to license private landlords as a way of improving the quality of privately rented accommodation. So they're very diverse projects, all local projects, but of course, some of them are quite large. So the London-wide HIV prevention programme that was evaluated was across the London area. So in summary, Phpes is successful. It generates research and practice impacts. It contributes to capacity building in research in both practice and in academia. It's valued by practitioners. Since it began, we've had 124 outline applications submitted, and there are ongoing inquiries about future funding calls. But as I say, there will continue to be geographical unevenness in the opportunities. And in that context, NIHR has now launched FIRST, which is the Public Health Intervention Responsive Studies teams, which have England-wide reach, which local authorities can apply to for evaluation of their initiatives. So in that context, SPHR3 will continue with Phpes, but we will probably strengthen our focus on the civil society or CVSFE sector. So thank you for listening. We're very proud of Phpes, and we're really pleased that it has influenced the new NIHR First initiative. So for more information on Phpes projects, please visit the Expo area. Thank you.